Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today, I'd like to welcome our guest, Dr. Chris Kleronomos. Thank you for joining us today, Chris.
Thank you, Linda. It's a pleasure.
Well, this is the first time we've had a chance to virtually talk.
Yes.
Have to get you at one of our conferences. So could you explain to the audience who you are and what you do?
Sure. Thank you. So I'm an integrated practitioner. I have a couple different degrees, a nurse practitioner, which is primarily a US degree. It's a mid-level provider. And then I have a doctorate in natural medicine and a master's in something called functional medicine. Um, Several different board certifications, et cetera. And I kind of mush that all together. And do, integrated medicine. My entire career has been chronic pain. And now I've become sort of the complex chronic pain fatigue guy, mainly doing a lot of centralized pain syndromes of various sorts, be it from direct pain generating conditions to secondary pain syndromes. Um, so that's kind of been my focus for the entirety of my career. Beyond that, which is much more fun, married, kids. I have a giant dog, which I have to show you because I'm a crazy dog person. There he is, Buddha. Okay, he's very tired from working. He is our clinic dog. Um, so he actually hangs out with patients and sits in the therapy room and things like that. And so we have currently a multidisciplinary clinic with a variety of providers, psychologists, naturopaths, acupuncture, interventional pain management, um, all of it. And we take a loosely structured program-based approach to that process. Um, so the way I view complex pain is to treat it via a multi-systems approach. So that's kind of developed over the years, and that is me in a nutshell.
Wonderful. I mean, if you just treat symptoms, you're not getting rid of the cause, what is causing the pain in the first place. So you have to dig deep to actually get there.
You
So
do.
patients that, I mean, with the opioid crisis, it's not just in the US, it's in the UK and many other countries as well. Do you have patients come to you that are on opioids, but they're not effective anymore and they don't know what to do with their pain?
Oh, quite often. We spend a lot of time actually getting people off of their opioids, um, and even some of their other drugs. Do I still prescribe them in select cases? I do. But for the most part, I am not a giant advocate. I think they have their place, but I think they've generally speaking caused a lot more harm than good. In fairness, however, I only see the patients that it's tended not to work. So, I will throw that out there. But we tend to be kind of the what we affectionately say is the last ditcher clinic. Um, and so, yeah, we do get a lot of those people where they didn't know what else to do and just kept getting escalated doses of the opioids.
Mhm. Because with the opioids, the dose that you start on when it works wears off and you have to increase it and then increase it. And people tell me that they end up on a cocktail of pain medications, but there still comes a point where they're not working. Where do you go from there? And when you get on like morphine and drugs like that, it's not good for your organs either, is it? So,
No, we actually see a lot of hormonal imbalance generated from that, particularly in younger people. A lot of neurotransmitter in the brain imbalances that occur from that. And then, of course, unintentionally, there's a difference between dependency and addiction, right? Addiction tends to have maladaptive behaviors associated with it, right? Like that you would picture from a movie or a TV show. But a lot of people are, I'm going to air quote here, medically addicted, right? They're dependent on this and they've developed these sick roles and these behaviors around it because that's all anyone has ever handed them, right? And so now you have this giant fear-based response. You have a dependency on this. You have a timing and cyclical variation that actually affects pain from a psychological perspective, right? Oh, I took my medication at 8 a.m. Oh my God, it's 1. I missed my dose, and immediately your pain ramps up because you have this tie-in, and these are unintentional, non-deliberate, but they still cause the physical symptoms, right? Our brain is incredibly powerful. Um, and they don't work. And I see this all the time. Somebody will come in and I'll say, I think this is the wrong drug. It's clearly not working. You don't have any functional improvements. This is why I think this. Let's do XYZ. And almost across the board, the phrase we would get here in the US is, but it takes the edge off. It takes the edge off, right? And I say, well, you just got done telling me that your pain level is a 7 or an 8 on average, right? And then I have a chart with pictures and smiley faces and word descriptions and little funny pictures, like every possibility to make sure that their pain reporting is as accurate as I can get it, right? For that person. But it's a very shift in their consciousness to sort of step back and say, wait a minute, yes, I did just say to you XYZ. I filled out all these screening forms because we have a lot to particularly find this out. And it's almost a shock to them, right? Because they haven't had that perception, that context before.
And it's scary trying to come off the medications, knowing that you could suffer terrible withdrawal symptoms. How do you coach people when you try and get them off of opioids?
Um, so if they're willing to, participate in getting better, I typically see people once or twice a week. I hold their hand the whole way and we do a gradual reduction. And if we need to, there are some medications that can kind of manage some of those symptoms, clonidines and nausea medications and propanolols. And, there's some things. I honestly don't have to use them that often. If you do go slow and do it appropriately, it's manageable, especially from higher doses. It's actually a little bit more difficult in the lower end of things because there's less of a percentage to reduce, right? If you have 100 and you take away 20, there's still 80 left. But if you have 10 and you take away 2%, it's a bigger sort of proportional difference in the dose. That was probably bad math, but you get the gist, right?
Yes.
It's a different proportional sort of adjustment, and that's actually harder at the bottom end. And you know, I would say, I mean, there's probably not a way to get zero withdrawal symptoms, but keeping them very mild and tolerable tends to be better. And I would say, honestly, 9 out of 10 people feel better after being off of them for a week or two than they did on them.
Mhm. Yes, I get that. I know that you prescribe LDN. Do
I
you
do.
use any microdosing alongside of the opioids to help people get off the opioids?
I haven't. Well, I shouldn't say I haven't ever, but I've only had 1 or 2 patients that had that initiated prior to coming to me, and I did maintain it. I like to sort of fresh slate people myself. That's the approach I take because I want to be able to emphasize that multi-system piece, right, and take it in chunks because we're not just using the LDN for pain, we're using it for all of those background things that it's doing, right? And I want to be able to leverage that, if you will, right? Um, but we do tend to, at those lower doses, try and bridge them over at that moment and gradually build them up in those last moments. So it's not quite microdosing, but it is a bridging process at the end.
And you mentioned acupuncture. Do you
Mhm.
find that's very successful for patients with pain?
I do, but I do. The caveat and the difficulty with acupuncture is the frequency, right? It's acupuncture is essentially, if you considered it a drug, you still have the dose and duration issue, right? So the frequency is required. We can cheat a little bit and put in like semi-permanent ear tax for a couple days, ear darts, ear tax, things like that. I would say on average, most people in the US would go to an acupuncturist, at best twice a week, and that's pretty aggressive. If you compared that to, say, China or South Korea or Japan, I'm less familiar with, but Korea or China, you're talking about twice a day.
Mm.
Right. And then there's the style that has a difference. I tend to practice a more medical-based, biomedical-based approach. I do use some traditional points that have classic indications for that. Um, but I'm trying to physically change the pain generators. Right.
Mhm.
And so it is incredibly effective for withdrawal, for lots of things. And, there's a World Health Organization chart that you can look at where they graded all the efficacy for various things. And that's true. I think the big limitation is just people's ability to access it as frequently as it should be.
I can remember having acupuncture, a Chinese clinic, and they used cups where they burn the air out of the cup and then it sucks.
Yeah.
Oh, that was painful because
Yes.
the cup goes over the needle, doesn't it?
It can. It can. Typically, I do it separately. We do a lot of cupping and extracorporeal shockwave and cryo and if you name it, we probably are doing it. Because not everybody needs the same things. And there is often times, I'd like to say, oh, I'm so brilliant and I know this person needs this intervention and that. But I would say probably more often than not, I'm surprised when I think whenever I tell myself this is it, I'm gonna nail this and here we go. That's the time it never works, right? And then I pull something out of my hat. Um, but I mean, we'll even go so far as to do, apipuncture with bee venom.
I've got no idea what that is.
Yeah, that's a whole different lecture. Uh, but often LDN is one of our very base treatments for lots of things, particularly the central pain syndromes and autoimmune generated syndromes for sure.
Mhm. And what kind of age bracket are your patients?
I would say the my baseline is probably 30 to 60. Um, uh, Generally probably a middle-aged female would be my
Okay.
um, I'm typically known for air quoting again here, fibromyalgia. Right, that's how they kind of access it. Rheumatologists here don't like to treat it. Pain doctors don't like to treat it because there's nothing to inject, there's no drug to give. Well, there are, but they've usually tried them. And so then that's how they usually end up in our door.
Mhm. So whereabouts are you?
We're in Oregon, just right in Portland area.
Oh, well, you'll have to come and be a speaker next year at our conference. Guess where it is?
I'm gonna guess NUNM.
Portland in Oregon.
Okay, well that's fantastic. I would love that. I'm actually good friends with Dr. Anderson, so
Okay, yes. Well,
yeah,
Paul's one of our medical advisors. Well, that's fantastic. I'll put that in the email too. So
Yeah. Yeah.
that's
I just lectured at his conference, so not
good.
too long.
Wonderful. Um, so how do people get an appointment to see you? Do you have a waiting list?
No, actually, we're unfortunately we're in the middle of transitioning the clinic, but we typically got people in less than a couple weeks. Um, we have very long appointments. Like I said, it was sort of this loosely structured multidisciplinary model, right? That's the model we did. So they'd have a 90-minute appointment with me. We would go through all the options. I would try and explain to them if I was able to sort of at least have a good idea of what was going on at that initial appointment. I'd try and outline that. We had whiteboards to draw it out for people. And then we would have a treatment review because it's a fire hose of information, and often patients are overwhelmed by just everything that has to happen to get them better. So we'd kind of come back and say, this is what we talked about. This is what we can do. Are you ready? Right. Um, we did take insurance. We were hybrid, but the majority of treatments, unfortunately, were not covered in the US. Um, even things that, even without being, weird voodoo, naturopathic, things like that, even without those things that should be covered were not typically. And then we would address it system by system, layer by layer. And
Mhm.
they would be seeing other providers as well, physical medicine, acupuncture, cupping, like you mentioned, shockwave. If they needed actual nerve blocks or spinal injections, the anesthesiologist would do those. They would see the psychologist. Um, we typically, if they agreed, we liked to do a lot of what's called a stellate ganglion block, which sits next to the vagal nerve on the neck to reduce sympathetic tone, a lot of peptide combinations, extensive labs, and then a lot of equipment, hyperbarics, red lights, pulse electromagnets, et cetera. And
Mhm.
it would be an average person would come an average of twice a week for about 3 months with a few extra visits in there, depending on, what they needed in particular.
Mm. I mean, hyperbaric oxygen, I think, is amazing. It's not very easy to find someone with a tank around where I am anyway.
Yeah.
That's difficult. I actually went to a clinic in Germany and I had it was straight into the bloodstream. So you had a cannula and it was oxygen. So they oxygenated the blood. I've got
Like a
MS and it was amazing. It was, you could feel it. You, it was like being given energy. It was quite amazing. And I think I did that 3 times a week for 2 weeks or something like that. It was really good. I mean, is that something you do over there or not?
So if I'm correct, I think, are you talking about ozone therapy?
Um,
Because there's a lot of I don't do ozone myself. We have something similar, but there are a lot of practitioners that have ozone in the US. It's
right.
quite popular. It's what's called an oxidative therapy, right? We produce oxidative stresses and then it does something called a redox. Actually, Paul is sort of one of the experts on this subject. So I better be careful what I say. He'll email me. Um, the so that sort of forces the body into this process, um, forcing that cellular exchange into the redox pathway, which causes cellular energy to improve and exchange of nutrients and elimination of waste and all those things. So it is good. There's several ways to do it. I typically do it with hydrogen peroxide and peptides, and some equipment. But it's a good therapy. There's lots and lots of therapies that are needed for pain, right? There's some certainly key foundational pieces, and then some things we know this kind of works for 90% of people, and then it kind of narrows down from there, right? But if layered appropriately, I mean, I've been doing this my entire career for 16 years, so it's kind of my context, and I don't want to say it's easy, but it should be much easier to access than it is for people, right? The exact protocols, are hard because people do need some individualization, but the baseline protocols, like we know XYZ works, and if layered appropriately, it should work. It's just being able to access it all in a single place, which was the model we were attempting to have.
Mm, sounds amazing. What you are describing as what is normal approach for you is very foreign to a lot of doctors, unfortunately.
Yeah.
And
Yes. And if
that
honest, it's
yeah,
it's
and that is why patients end up seeing so many doctors before they find someone like yourself.
right.
Because as I said before, treating the symptoms is just a band-aid, isn't it? It's not going to make you well. You've got to find the root cause of whatever condition it is. Now, you
Yeah.
said um, like middle-aged women with fibromyalgia. What is the youngest that you will treat in your clinic? Would you treat children or do they have to be 18?
They don't necessarily have to be 18, but I don't see children. Pediatric pain is very different. The biology is different. The brain isn't fully developed. The responses are different. We don't have drug data. I mean, and I don't want to say, I mean, I'm not opposed to Western medicine. There are times that it's necessary, and even times when I utilize it, even a drug I dislike, air quote, because I'm using it to buy time for the patient to get those other things going, right? The
Mhm.
natural, functional, integrated, whatever you want to call it, is a much slower process, right? It's not acute Western medicine. And so, if there's so much symptomology in the way, often a patient can't do the treatments required. And so I learned, pretty quickly on in my career that to say to somebody like, well, just give it 8 months while we're doing this very slow process that you're not going to notice, honestly, because it's working in the background,
Mm.
it is not going to work, right? So sometimes I do, 3, 6 months, even, a year. I just weaned a person off their narcotics that I had started because they were so symptomatic, over 2 years, and it took them about a year before they could, have the financial lump to get their IVs and all their things. They had been going through multiple surgeries and PT and all the basic stuff, so it took a year to get those foundations, and I maintained it was an opioid at the time. And now she's off and she's significantly functionally improved, and she's doing amazing. She's not cured. I don't claim to cure people. We all have something, right? The goal is, including me, um, the goal is manage and function and enjoy your life, right? With limited burden of all these other things, right? So we even if we have to use drugs, we try to be selective, right? If you use more than 6 to 8 drugs, there's 100% drug interaction. We don't know what it's doing. You might not notice, but it is happening.
Mm. I mean, the number of people that tell me, typically fibromyalgia people who are ultra sensitive to drugs anyway, but they'll say, I'm taking 14 different drugs.
Right.
14. But once I'd taken the first five, I then had to take another pill to combat the side effects from those five. And then I was okay. But then when I added four more, I had to take another pill because of the side effects. And that's just crazy, isn't it? Absolutely crazy. But people with fibromyalgia that get on LDN and get the pain under control can generally drop to like four or less of those medications over time. I mean,
Yeah,
it's all slow and it's all a work in progress. And of course, when you're 20 years old, you don't think about health and medication. You're just living life, aren't you? And it's not until you
sure,
get
sure.
older and life has taken a toll on your body that things crop up.
Yeah, for sure. And LDN's amazing for central pain syndromes. In fact, there was finally just a fairly recent article in a Western pain journal um, that said, I'm going to paraphrase here, but it went so far as to finally say pain doctors should strongly consider the addition of low dose naltrexone for recalcitrant chronic pain. Didn't commit to it, but at least it got published and at least it was thrown out there.
That's amazing, isn't it? Um, Pain specialist Dr. Norman Marcus had a paper published a month, 6 weeks ago, somewhere around about there. And he has his own protocol.
Hmm.
He does 4 times a day dosing,
Okay.
and he does it very, very low. And
Mhm.
he says that he can get fantastic results, get people off of opioids, he can get them pain free, but his regime is different to other people's. But it works, so
I,
it's
I
good.
wouldn't doubt that. I mean, I often do two. I mean, my baseline is twice daily dosing, and I'll sometimes go to 3 or 4. I mean, if you think about that mechanism at low dose, we don't get the complete binding, which is the intention, right? So you're kind of pulsing
Yeah.
that and tuning it over time, and that makes perfect sense, right? And I do think people do respond better to certainly the twice daily versus the 1 day. Um, the 3 and 4 day, I have a less robust amount of people to compare to, but certainly my baseline is twice a day.
Mhm. When you do twice a day, do you do equal dosing?
For the most part, I would say, the general target range that everybody, sort of always talks about is 4.5 milligrams, right? But I've done everything from, 1 mil, zero point 0.5 or 1 milligram to 9, right? I mean, I think as long as we don't cross a threshold where we start binding more than the intended, where we change the sort of pharmacokinetic, sorry, of the drug, we're okay. Um, and I think it's okay to play with it in that
Mhm.
range. I mean, it's at that point a little also about convenience and practicality and things like that.
It's what works best for the individual, isn't it, with
Right.
LDN? So
Yeah.
we've come to the end, but before we go, what breed is your dog? Was it an old
Ah,
English sheepdog?
no, that's what everybody thinks. He's actually a Saint Berdoodle. He is a
Really? Ah,
Yes, he is a Saint Bernard Doodle mix named Buddha.
I only saw part of him, and I was thinking,
Yes.
is he an old English sheepdog? So he's
Yes.
he's a
He
big
happens to be great. Buddha, do you think you can wake up and say hi to everybody? What do you think? What do you think? Where are you? No, very tired. He's very tired.
He's
Working
worked.
so hard.
Yeah,
Yeah.
this worked so hard. Thank you
Thank you.
very much. And it's been
All
amazing
right.
talking to you, Chris. Thank you.
Wonderful. You too. Take care.
Okay. Bye-bye.
I'm Dr. Leonard Weinstock, the guy who's been prescribing LDN since 2005, and I've seen the wonders. And I keep on seeing them, especially in hard to diagnose conditions. They're not that hard to do, but once you know about mast cell activation syndrome, postural orthostatic tachycardia syndrome, and Ehlers-Danlos syndrome, you'll find that 17% of your friends or relatives have one or more of these conditions, and you can help them. We're making a documentary to wake up the medical community, to educate the population, but we need funding. So please fund whatever you can afford, no matter how little. www.mcasfund.com. That's mcasfund.com.
Any questions or comments you may have, please email me, Linda, Linda, @ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.